The following podcast is part of a certified educational activity titled Addressing an Exacerbating Issue in COPD, Strategies for Individualized Targeted Biologic Therapy to Improve Quality of Life. Access the entire activity and complete the post-test at peerview.com/PTU860. Downloadable slides and practice aids are also available.
Good morning. Thank you for being here early in the morning. I'm Antonio Anzueto from University of Texas in San Antonio. My co-speaker is Professor David Singh from Manchester. Okay, so what's the objective to be here today? So we're going to talk about the role of cytokines such as IL-5, 32, TSP, play a key role driving inflammation and symptoms in COPD. We're going to discuss the current goal recommendation that we're going to hear a lot about that today and in the next couple of weeks that supports the clinical evidence for the use of biological therapies in patients with COPD exacerbations. We're going to discuss factors about biomarkers like eosinophils, exacerbations, history, lifespan, help to inform treatment planning to identify patients that may benefit from biological treatment. And biological therapies can be integrated into the personalized COPD care plans based on the latest data and patients' characteristics. So this is me. So the reason we are here today are the data presented on these slides. The fact that a lot of people come to this Gold Conference is because we have a problem with COPD. The problem with COPD starts from the fact that it's a progressive disease, that the symptoms produce a tremendous burden on the patient's everyday life. The prevalence of this condition is estimated to continue to increase up there at 23% all the way to 2050. And exacerbations that for many years we ignore and we say, oh, Mr. Johnson has his flare-up, I give antibiotics, he's going to be back 2 or 3 months, and in the winter more often. But we clearly recognize that it's not that easy, that exacerbations are the major drivers of morbidity and mortality in COPD, and the exacerbation is when we make the link on the interaction of cardiovascular conditions and cardiovascular risk in patients with COPD. And this results in significant number of deaths that should not be happening. So that's the reason we all are here today, and we're going to be here for the whole day, listen to these presentations. Certainly, if you go back to the 2001 Gold document, the items listed in your slide on pink and blue, they were proposed as the objectives for the treatment of COPD. You can imagine in 2001 when this was published, people said these people are crazy. So you're talking about you're going to relieve symptoms, you're going to increase exercise capacity, improve health status, decrease exacerbation, and decrease in mortality. Today, in 2025, this is a fact. This is happening. And one of the goals were established from one side to reduce symptoms. Because I can tell my patient, your lung function is going to be better, you'll have less exacerbations. My patient doesn't care. My patient rolls his eyes or her eyes and says, listen, I want to feel better. I want to be able to do more. So that's going to be pivotal in whatever we do in this condition. And the fact is that we have gone a long way with bronchodilators. You have a study in front of you 10 years ago, 12 years ago, and I have told you, hey, we're going to have in a single inhaler long-acting bronchodilators once or twice a day that will decrease 26% the risk of exacerbations, that will decrease by 30% all-cause mortality, that will improve your St. George as well as 100 mLs. You guys said, this guy is crazy, you have stood up and left. Today, we don't only have that, we have now information that in people who are not able to prevent exacerbations or don't get improvement for these therapies, if we add biologicals, we add other interventions, we can further improve this. Now, however, there is a large number of people that continue to exacerbate. I think it's important to highlight in the left side of the slide, it's the risk of exacerbation if you are in a single inhaler, and in the right side, if you are in the multiple inhaler. Certainly, multiple inhaler was what we have available, and we use it for many years. But today, this slide highlights that these are not the same. These are apples and oranges. And we have to be very careful because as you can see, the risk of exacerbation in a single inhaler is far less than the multiple inhalers. But despite that, the patients can continue to exacerbate. And those individuals, they exacerbate, we know they will have more declining lung function, they're going to feel worse, have more exacerbations, and go with this spiral. It has been suggested that should be like have to incorporate cardiovascular condition into this spiral. But the fact is that there are multiple organs. It's not only the lungs that will impact it. But these individuals who exacerbate, if you look on your left side, they are 54% have more severe airway obstruction. 79% will be symptomatic with MRCs more than 2. 1/3 of those patients require supplemental oxygen. We look in the middle, the prevalence of the cardiovascular conditions. Yes, I knew that my COPD patient has some cardiac disease and has some problems. But now that we are allow our patients are able to live longer, have better quality of life, I see these patients coming complaining of shortness of breath, spirometry is stable, everything looks great. I send it to the cardiologist, and they come back with 3 stains or the crack in their chest because the cardiovascular disease is able to manifest. And these patients, because they're having exacerbations, are more likely to have prescriptions of systemic steroids, and the annual exposure is significantly higher. So I'm making a point, we have gone a long way, but we still have a significant problem. So we need to look at what else can we do to reduce. Because the patients who exacerbate in the last month are very likely to have 69% one severe, or they can have 69% moderate or more than 25% severe exacerbation that can result in death. This condition can kill our patients. This is not a walk in the park. So we have to do everything that we can to understand the underlying mechanisms and provide our patients appropriate therapy. We are evolving in this understanding. Certainly, our brother disease, asthma, have taught us a lot of information on what could happen in COPD. But at the same time, our COPD patients are telling us, I'm not asthma. What you have applied for asthma, don't apply to me because it's not going to work. And study after study and intervention as intervention is showing us that COPD is unique. They have environmental conditions. They have inflammation in the airway. They already have what we want to prevent in asthma, that is airway remodeling. There is epithelial dysfunction, continued exposure. So the interventions at the inflammation level will have to be, we need to understand the mechanisms because we have to be tailored in order to work. And as you are aware, there had been multiple interventions. We have gone through different pathways and nothing has worked. So a few are beginning to show us promising. And that's what we need to bank and to understand why they work, what are the underlying mechanisms. For that, and this all the slide that you have want to see a lot of that in this program, I'm going to have David Singh discuss the unlocking the potential evidence of biological therapy and COPD. David.
So thank you, Antonio. So my job for the next 25 minutes is to give an overview of novel therapies. Antonio's just talked about targeting specific pathways, exacerbation risk, and optimizing treatment in a personalized manner. And that's what I'm going to cover. So I'll begin with looking at the GOLD recommendations, what they were before the 2026 update and what they're going to look like. I'll talk about optimization of inhaled therapy and then move on to the biologics that are now approved and the biologics that are in clinical trials. So briefly, here's the initial pharmacological treatment for COPD patients in the previous version of the GOLD document. Now, if you've been online, you'll be aware that there's a small but important change to this. One thing to stress, and I think this is sometimes misunderstood, is that this classification system, and it says it at the top, is only to be used for patients who are on no treatment. So when a patient comes to the physician and they're either newly diagnosed or for whatever reason they are on no inhaled therapy, you use this classification system. It's not for patients who are already on inhalers. So for the patient, their first prescription, you look at symptoms and exacerbation risk, and the 2026 GOLD document now groups A and B is for people with no exacerbations. The one exacerbation has moved up to Group E, and you'll hear more about that later on. But it tells you that we as a community of physicians, we in the GOLD Science Committee, realize that we need to take a much more aggressive approach and rapid approach to preventing exacerbations as they carry, even one exacerbation, a poor prognostic value. So for patients in Group E who have exacerbations, then the majority will be treated with a dual bronchodilator. But if you have evidence of type 2 inflammation using blood eosinophil counts, if it's above 300, it will be reasonable to commence the patient straight on triple therapy. And then the follow-up algorithms. So here's where you start to split out different treatment pathways according to the treatable traits of breathlessness or exacerbations. And of course, most patients who are exacerbating will also have a heavy burden of symptoms. So the patient comes back, they're already on inhaled treatment, and you need to decide what to do next because you've decided they need more treatment. Well, if they're breathless, you optimize bronchodilator therapy. They'll probably step up to dual bronchodilator therapy. You'll think carefully whether they're adherent, look at their inhaler device, you'll manage comorbidities. And one of the advances I'll show you in the next slide is there's the possibility to add an inhaled bifunctional molecule, a PDE3/4 inhibitor, ensifentrine. If the patient's experiencing exacerbations, and really one exacerbation then is the signal to optimize management, for inhaled therapy, the escalation is based on the evidence of type 2 inflammation. So there are various arrows here with different eosinophil thresholds, and people sometimes find this a bit confusing. So hopefully I'm going to simplify this for you now. If a patient has a blood eosinophil count above 300, you could call that type 2 high. And that's when you just go straight to triple therapy. And it was there on the previous slide. That patient, even on the basis of one eosinophil count above 300, has evidence of susceptibility to developing a high level of type 2 inflammation. If the patient has an eosinophil count between 100 to 300, there's still evidence of type 2 inflammation. But there, if not already on a dual bronchodilator, you have time to do that first, and then if needed, then step up to triple. So for patients already on triple therapy and they're suffering with one or more exacerbations, what do you do next? Well, that's where you use a combination of clinical characteristics and biomarkers to decide. So you see here that, again, for patients with type 2 inflammation, you could choose a biologic that targets these pathways, dupilumab, if they also have chronic bronchitis, or mepolizumab, irrespective of the presence of chronic bronchitis. Alternatively, if there's no evidence of type 2 inflammation, you can consider roflumilast for patients who have lower FEV1, less than 50%, and chronic bronchitis, or in former smokers, azithromycin. So we're using clinical characteristics such as bronchitis, are they active smokers at this point in time, and biomarker characteristics to decide how to optimize treatment in those who are exacerbating while on triple therapy. So I said I would briefly mention ensifentrine. So the ENHANCE studies, a pair of phase 3 studies done over 6 months, were focused on lung function and symptoms. And you'll see lots of data there. I'm not going to read it all out. But both studies provided convincing evidence that for patients who are breathless, when you add on this inhaled molecule to existing treatment, that there was an improvement in lung function, also symptoms and quality of life. But there are some gaps in knowledge. These individuals were not enriched for exacerbation history, and therefore, though there was a reduction in exacerbations, the exacerbation rate was low, so we need to know more about that. And none of the patients in these studies were on triple therapy. So hopefully we'll have more information on that in future. But coming back to the exacerbation algorithm then, what I articulated to you previously, for patients on triple therapy, we're using clinical information, which we call phenotype, and we're using biological information, which we call endotype. And I think sometimes these terms get slightly confused. It's the biology, the complex biology, the endotype that patients have, and COPD is a complex disease composed of many components, so patients therefore have multiple endotypes. And those pathways give you the clinical presentation. So ideally, one wants to capture both the biology and the clinical presentation to make the right treatment decision. So to bring this to life, I'll give you an example of something we already do in clinical practice, apart from measuring blood eosinophil counts. And it's alpha-1 antitrypsin deficiency. So the clinical phenotype is the non-smoker who develops emphysema at a young age, and that raises a suspicion. You ask for the family history. You'll measure the biology. You'll look at the alpha-1 antitrypsin levels. You'll measure the genotype. And you'll marry that all together to give you the diagnosis and to come to the right treatment decision. So that's precision medicine. And we're now doing that then for patients who have cigarette smoking related COPD or non-smoking related COPD, such as indoor and outdoor pollution. So what are the key clinical characteristics that we look at to try and follow this precision medicine approach? Well, you saw on the follow-up algorithm, we look at breathlessness specifically. That guides optimization of bronchodilator therapy. We look at exacerbations, and one exacerbation is a signal to reconsider management. We look at current smoking. The evidence for azithromycin is stronger in former smokers. And we look at the presence of chronic bronchitis because the studies done with roflumilast, the PDE4 inhibitor, were in patients with chronic bronchitis, and the studies done with dupilumab, the monoclonal antibody that targets IL-4 and 13, were done in patients who have chronic bronchitis. And then we look at the biomarker characteristics to identify patients with type 2 inflammation. So I'll go through this in more detail, but the biologic studies with dupilumab and mepolizumab use blood eosinophil counts as an entry criteria, so above 300. Exhaled nitric oxide, there's evidence from the biologic studies that there is an enhancement of efficacy in some of the studies in patients who have higher exhaled nitric oxide. IgE in some individuals might also be useful. And all of these seem to relate to increased exacerbation susceptibility. Here's a brief summary of blood eosinophils and COPD. And this was published by some of us in the Gold Science Committee before the registration of biologics. So if we were to rewrite it now, biologics would be on there as well. But blood eosinophil counts are a continuum. The higher the count, the more likely you are to have type 2 inflammation. And I've used the phrase already. In my view, I think about it as susceptibility to type 2 inflammation. There is some worry about repeated counts, that they vary. Well, I would say that's natural. if you have a human inflammatory disease, it's never that the inflammation stays completely constant from day to day. Now, I often use this example, but if you were a rheumatologist and you repetitively measured the CRP, you would never expect it to be repetitively the same number, 30, then 30, then 30, etc. So we shouldn't expect an inflammatory marker in COPD to come back with exactly the same number. The way I think about blood eosinophil counts is they are a biomarker in the blood that tell you the patient has type 2 inflammation in the lungs. The biomarker in the blood will vary, but if you find even once it's high, it tells you that this individual in front of you has a susceptibility to developing type 2 inflammation. So you don't need to measure it repetitively to reassure yourself that it's high every single time, because that won't happen. Now, at the lower end of blood eosinophil counts, those patients don't have type 2 inflammation, and they represent an interesting group because some of them behave a bit more like bronchiectasis without necessarily having bronchiectasis on a CT scan. And they have a disordered microbiome with more likelihood of colonization with proteobacteria. A brief summary then, that before considering using one of these add-on treatments to triple therapy, it's important to holistically assess the patient. Clearly the history of exacerbations is what we commonly use to think about future exacerbation risk. But patients with lower lung function, they also have a higher exacerbation risk. But remember, even patients with mild to moderate airflow obstruction do exacerbate. Those patients with more symptoms seem to have a higher risk of exacerbations. Doing a CT scan is extremely useful. I do a high-resolution CT scan in all my patients. You may find concurrent lung pathology, bronchiectasis, for example. Antonio mentioned it earlier. Mucus plugs, an emerging field, they relate to increased exacerbation risk. Bacterial colonization then at the lower end of eosinophil counts, a specific phenotype. Immunoglobulin deficiency, you may need to look for. Other comorbidities, such as reflux, airway collapse, and then biomarkers, type 2 biomarkers. So this represents a more comprehensive assessment that we should be doing. So for the patient, during follow-up, we want to do those clinical assessments. We want to judge their exacerbation risk. We want to make sure that the triple therapy that they have is optimized. Is it single inhaler triple therapy? Are they on the right device for them, a dry powder, a metered dose inhaler? Do they understand how to use it? Is adherence good? All these things. And then we want to assess for type 2 inflammation. And for those who have a single blood eosinophil count above 300, that would make you think about using a type 2 biologic. So here are the two biologics that have achieved regulatory approval. I've listed out the studies, the phase 3 studies that were done. There are some similarities and differences between the studies in terms of their inclusion criteria. So all the studies were done in COPD patients who were already on triple therapy, and they had in the past year 2 moderate or 1 severe exacerbation. So there's some common inclusion criteria. For the dupilumab studies, the patients were also required to have a history of chronic bronchitis, so the traditional definition of 3 months in the last year of chronic sputum production. So for the mepolizumab studies, there was not an inclusion criteria of chronic bronchitis. Both studies used blood eosinophil criteria. For dupilumab, it was at screening, the blood count had to be above 300 eosinophils per microliter. For the mepolizumab studies, it was slightly more complicated. In the first 2 studies that were done, METRIX and METRIO, 2 blood eosinophil counts were done. You could either get in because you had a blood eosinophil count of more than 150 at screening, or your historic count was more than 300. So either of those 2 would get you into the study. Either. Now, in the matinee study, which is the most recent, slightly different. So it was more than 150 in the last year and 300 at the point of screening. So evidence from 2 counts, whereas Metrix and Metria was evidence from 1 count. Now, the indication there, the license indication in the US is written there for you. So both of them have similar indications. It's add-on therapy for patients with an eosinophilic phenotype. And the dosing regimes are listed out for you. So let's look at the results. So this is the pooled data from the 2 dupilumab studies, the Notus and Borea studies. And overall, there was a 31% exacerbation rate reduction. Alongside this, there was an improvement in lung function. So dupilumab blocks the signaling of IL-4 and IL-13. IL-13 is probably very important here. IL-13 causes a number of effects that could be relevant here. So IL-13 itself causes smooth muscle hyperplasia and constriction, also mucus hypersecretion. And blocking this then could be the reason for this improvement in lung function. What I find interesting is the lung function improvement is quite early on. You can see it as early as 2 to 4 weeks. And I think that's an effect that's independent of exacerbation prevention. Now let's have a look at the mepolizumab studies. So here are the first studies. So you can see here. So here's the matinee study. Sorry. So what we have here is a 21% exacerbation rate reduction. And the eosinophil criteria, just to remind you, are written across the top. So here you had to have it done twice to confirm that you had type 2 inflammation. And here are the previous studies. So the Metrix study was positive with an 18% exacerbation rate reduction. So 2 positive phase 3 studies. The Metrix study was not positive. But we have 2 studies here showing 18 to 21% exacerbation rate reduction. Blocking interleukin-5 stops eosinophil production and recruitment into the lungs. So 2 differing mechanisms of actions for these biologics. So these are great advances, but what are the limitations? So we have 2 type 2 biologics here. The studies were done in individuals with higher blood eosinophil counts, and 300 is a reasonable threshold to use. Blood eosinophil counts do vary, but I would just use a single count. If you have evidence from 1 count over the year, even if you have multiple counts, that tells you the patient has a susceptibility to type 2 inflammation. However, what about the rest of the patients? And their COPD is essentially an epithelial-driven disease. Cigarette smoke, particulate matter damages the epithelium, and that's where the family of cytokines alarmins could be important here in driving a broad pathway. And Antonia showed you this earlier. 2 of the alarmins that I'm going to go through are interleukin-33 and TSLP, thymic stromal lymphopoietin. These are released by the epithelium. Now, they're lumped together here as one, and I don't really have time to go through this in detail. You could give a whole lecture on this. They actually are very different. They act on different receptors, so TSLP, and I'll talk about TSLP in depth later this morning. It acts on the TSLP receptor. IL-33 acts predominantly on the ST2 receptor. They signal through different pathways as well. TSLP signals through JAK-STAT pathways, IL-33 through NF-kappa B and other pathways. But there is some commonality. So they both act on ILC2 cells and both then drop the blood eosinophil count. So they both definitely have an effect on type 2 inflammation. But they also have effects on other non-type 2 pathways. So that gives them the potential, and I say potential, to be broader acting than the type 2 biologics that you've just seen. So I'm going to go through the phase 2 studies that have been published for these biologics. So first of all, let's look at an anti-TSLP biologic, tezepelumab. Just a point to make about phase 2 studies, these are never definitive. Phase 2 studies are to get a signal that might give you confidence to go to phase 3 or to work out the right population. So this study, the core study, was done in patients at high risk of exacerbations. They received tezepelumab on top of triple therapy for a year. So in the whole population, there was a 17% exacerbation rate reduction. It was not significant. Now, if you were looking at this as a phase 3 study, you would say it failed. I view this study as a success. Why? As a predefined analysis, we split the patients into different subgroups, and we saw the effect got bigger with more evidence of type 2 inflammation. So remember that 150 to 300, there's still type 2 inflammation. The effect went up to 34%. And at more than 300, it was a 46% exacerbation rate reduction. No effect of cigarette smoking. At higher FeNO levels, 54% exacerbation rate reduction. No difference in those with and without severe exacerbations in the last year, but those with 3 or more exacerbations, the effect was bigger, 30% exacerbation rate reduction. And there was an almost 50% reduction of hospitalizations. So while the primary endpoint didn't reach significance, there was plenty of information that the more type 2 inflammation you had, you were more likely to respond. And the phase 3 studies are now ongoing in COPD patients with a history of exacerbations and more than 150 eosinophils per microliter. So let's look at an anti-IL-33 antibody, tozorakimab. So here, again, a phase 2 study. This is much smaller. The previous study had hundreds of patients in it, 350. Here, we have about 120 patients. It's a 6-month study, again, a phase 2 study looking for signals of efficacy. So there was a small improvement in lung function, about 20 mils throughout the course of the study. The inclusion criteria was 1 exacerbation in the last year. When you split this out for patients who had 2 in the last year, that went up to 60 mils. We also looked at COMPEX, which is symptom worsenings and exacerbations. There was a 21% reduction in COMPEX. And again, when you looked at those with 2 exacerbations, the effect got bigger. But one of the interesting things is we did a sub-study with high-resolution CT scanning, and there was a signal for a reduction in mucus plugging. And there are biological pathways by which IL-33, so it's normally in the reduced form, but there is an oxidized form, and the oxidized form signals through the RAGE EGFR pathway to cause mucus hypersecretion. And this is potentially really interesting. So all of this in this phase 2 study for an anti-IL-33 antagonist gives you a signal of efficacy, and it tells you about a potential treatment mechanism. So there are other monoclonal antibodies that either are currently in studies or have just finished. So the Resolute study for benralizumab showed a numerical improvement, but not statistically significant. There are 4 other phase 3 studies. So for itepekimab, an anti-IL-33, astegolimab, an anti-ST2, so that's the receptor for IL-33. So 2 studies for itepekimab, 2 for astegolimab. So slightly mixed results. For itepekimab, 1 of the phase 3 studies was positive and not the other. For astegolimab, again, 1 of the phase 3 studies was positive. The other one had a similar effect size, but was not statistically positive. Now, I can't go through these studies in detail because the full results are not there in publication form. These are just press releases. So hopefully we'll learn more, and it may tell us more about responder populations. So this brings me to the last slide. It is an exciting time in terms of COPD pharmacological treatment. We already have huge advance in terms of the fact that we have type 2 biologics. Moving forward, there is a need for biologics that target beyond type 2. The key to this will be patient selection, understanding biomarkers that help us find the right patients. Maybe the studies should encompass other aspects and design, such as looking at disease progression, intervening in patients earlier in the course of the disease. And there are also some studies have been done looking at patients during exacerbations. So plenty of scope for investigations in the future to optimize the prevention of exacerbations in patients with COPD. So thank you for listening, and I'm going to hand back over to Antonio, who will lead us through the case discussions.
Well, thank you, David, for this overview. So we have some clinical cases because the bottom line is where these medications we're going to be able to use. This is a lady, a 55-year-old, happened to smoke, not smoking anymore. She has significant limitation on her physical activity despite being on triple therapy. She knows how to use her medication. And the other important issue is it keeps showing in a lot of data and studies is the continuous or the need to use those SABAs tells you there is a problem. A person is not fully controlled. So you have here the symptoms of dyspnea. A patient was admitted with a COPD exacerbation 3 months ago. He has comorbidities, cardiovascular, high cholesterol, anxiety. And when we do the objective assessments, the CAT score is 21, has an MRC of 3. He has 7 in the board scale when he starts walking. He has 5% eosinophils. Your physical exam shows you obstruction, and the CAT scans will show you upper lobes emphysematous. And her respirometry shows COPD, shows obstruction, as well as a 50% with this very small bronchodilator response. So what should we do in this lady? Certainly, we need to continue with her pharmacotherapy. We need to continue with the SABAs. We need to, one of the big issues that we have emphasized in the GOLD document, and I see in my patients, even in my patients in private practices, are you taking your medications? You know, when they hit this donut hole in Medicare and the insurance changes the copayments and overnight goes from $500 to $300, a lot of patients don't do it. So I always emphasize and tell me, talk to me, you have those problems, let me know. I will get your sample. We find a way to get your medications. Because I think that could be a pivotal to understand that what's happening is a failure despite patient is optimal treatment or it's a lack of compliance due to some other reasons. And certainly in 2025, here the consideration will be a biological. We need to remind, and we call document we emphasize non-pharmacological pulmonary rehab. The importance of that is not only that they are in one place doing exercise, is there are people with their same condition. They are sitting next to each other and they can talk about it. Say, hey, how do you do this? Hey, how do you do that in your life? I've never been short of breath. I don't know what it means to be short of breath. I cannot advise my patients. But among them, they can talk about this. And I have many times patients come out with ideas and some things that they do that they learn from their peers in the rehab. So I think we should not underemphasize the need for rehab or support groups or place where people can talk. Diet is hot. Okay, so 4 months later, she did have a biological, comes back to see you, hasn't had exacerbations. Her symptoms are better. Her CAT went from 21 to 12, MRC from 3 to 7. Her board scale have decreased. Lung function improved a little bit. But I think at the end of the day, what is more important in this lady, she has significant improvement in her symptoms that will guarantee that she will continue the treatment. And the challenge that I have in some of those patients after they've been on these medications is like, hey, do I need to continue to use my inhalers? Can I stop using my inhalers? I feel great. But, we have been there in asthma. And we tried to understand at one point we need to taper that. In COPD, I don't think we're there. We don't understand. And I tell my patients, try not to use your SABA, keep with your other inhalers. So let's show you another case. This is a gentleman in his 60s. He again stopped smoking, I think we need to emphasize this smoking cessation, although I'm 100% convinced that all my patients who continue to smoke, they want to stop, but they can't. But this is horrible addiction. But I tell them an alternative is not electronic cigarettes or pods or nicotine, stuff like that. That is not an alternative because we don't know how much harm you can have of that. Just try to taper down your cigarettes. So he's on triple therapy with good adherence. Eosinophils 200, had 2 moderate exacerbations in the last year, has persistent dyspnea, shortness of breath. And the challenge of him is he's being treated, but he continues to exacerbate. So in a person like John, we need to ask questions, how should we treat it? How do we need to look at it? Do we need to other medications, other alternatives in the treatment? Will he be a candidate with biologicals with a serum eosinophil of 200? Certainly, if we cannot show a higher number, the insurance will say no. I will have to be dealing with the insurance company and advocate for that. But it's also important, although the number of clinical trials that are available today for biologicals had decreased. At one point, a lot of these patients were candidates. They were willing to participate in clinical trials because it would allow them to get access to these medications as well to understand in a situation like him, he or she will be a candidate. In his case, especially with the eosinophils below. So we have alternatives. We need to look at other molecules. We don't have data that in individuals on triple therapy where you add ensifentrine, as David showed you. But in the future, we may have to answer those questions. If a biological is not an alternative, what other medications could be an alternative in an individual on triple therapy already optimized? The last lady is Sarah, who's 58. And I think you notice that our female ladies are younger, and this was done in purpose because it's important to relay the message that the epidemic on COPD is not in a 78-year-old male who maybe he continues or has stopped smoking. The epidemic is in a lady in her 50s that for a reason we don't understand, the disease will progress and we have to intervene. She's on triple therapy, occasionally uses SAVAS, has her quizzes, cough, had 1 exacerbation the last year, but Sarah will continue to smoke. She tells me, I can stop, I can go through everything. I tell my patients, you must set rules, not smoking inside the house, not smoking in close environment, not smoking around grandchildren, children. You want to smoke, go outside, try to limit as much as you can. But as we understand, is the addiction and the center is something horrible that they have to experience, knowing that something bad is going to happen today. It's like you decide, I'm going to run all the red lights of Philly in the next 24 hours. You're not going to have an accident. You're going to have a big wreck. I mean, it is impossible have an accident. These patients know there is something bad is going to happen today. It's not their lungs, it's their heart or something, but they just can't. But we need to continue to work with them. So here, certainly, we should ask about the managed active smoking. We need to talk about pharmacotherapy. We should be a candidate for biologicals. We should probably check her eosinophils. We do have data now. We have secondary analysis from the dupilumab trials and from the mepolizumab trials that the response were similar in active and former smokers. On the alarmins, there was on a phase 2 some differences, but we have to wait until the phase 3 trials to see that. And certainly, one of the big issues we have to address is how can lifestyle factors, should we be impacting and should we continue to address? When you look at the smoking cessation studies, 80% of the patients said, my doctor, my healthcare provider knew that I continued to smoke and he or she didn't say anything. I think our responsibility is to tell them all the time, hey, those aims have to go. I have the tools to help you when you are ready to get rid of those aims. So we need to emphasize that. But so far, as the biologicals that we have available, doesn't seem to be a difference in efficacy response.
So we have some questions. So one of the questions is, which eosinophil count do you use? Baseline, during exacerbations, average, multiple? So Antonio, you presented your first case. The eosinophil count was actually done during an exacerbation. And it was a high eosinophil count. Would you consider that count is suitable for starting a biologic?
So I think there's a couple issues, Dave. The first issue is, are we doing eosinophil counts? I think that's the first challenge that we have. And in our institution, everybody who walks through the door has any respiratory symptoms. They will get part of the things that they get a CBC with differential. Because we need to understand, we need to know that. The first case, actually, those eosinophil levels were in a steady state. Now, but it brings this issue of, if sometimes was elevated 3 years ago or 6 months ago was 500. Today you check that, it's 150. What is the value that you're going to use? How does that work? And that's what I mentioned before, how, asthma and COPD they are different. David had publications who had looked in COPD at that variability on zero eosinophil levels. So patients can change. Conditions can be environmental conditions, other conditions can produce those changes. So we have to be aware of that. If, for example, my patient at one point was in 500, now that when I saw them it was 150, my inclination will be to say, yes, that person has type 2 inflammation. And if I don't have any additional therapy, so biological is an alternative, I will advocate to get that.
Yeah, so can I just add something? So I agree with that a single high reading then is enough to convince me that this patient has type 2 and should have a biologic. But a single low reading, it may be a false negative. So that patient may still have type 2 inflammation, and I would repeat it once or twice to convince yourself that there is no evidence of type 2 inflammation. Would you agree with that, Antonio?
Well, it depends what does a single low reading means. A single low reading of less than 100 or 50, or a really low level, and you repeat again, it's low, I say, no, this person doesn't have that. But the challenge is when you are between 150 and 250 in movie. It's about 250 to 200. That's the range that is a little more challenging. And I will agree. I will repeat it.
Yeah. Okay. So just move on with the questions. Can you just doing these in order? Can you comment why were the studies with Fasenra, benralizumab, so benralizumab in COPD negative? Did they not select the right patients in the studies?
So as David shows, there is not only one mechanism. There are three mechanisms that the studies, the reports of the study, the press release of the reports of the studies were negative. So we had to look at the data to understand. My bias, and I show you their point about what is triple therapy, is not the same. Open triple therapy and closed triple therapy will decrease significant your risk of exacerbations. And we look at that in the control group in the mepolizumab trials, in the matinee, and 3 years early in the METRIC study. If you look at the baseline control, exacerbations were 1.7, now it's 1.2. When we look in the dupilumab trials, the control group, we're talking about 1.1 exacerbations. So how the patients were treated, I think that may probably have an important role. So we have to have the publications. We have to see what was the patient selection, because that will help us to answer this important question. And this is pivotal for future studies, because we don't want to limit interventions and say, oh, the studies were negative because we studies were not in the wrong population. That's why we have to, as new medications get developed, it's crucial to understand what makes that negative in order to move forward.
So here's a good question. So in a patient with COPD and increased blood eosinophil count, how do you decide which biologic to use? What are the differences between dupilumab and mepo? So if I'll just make a comment first, briefly. So I think we're in the same situation that the asthma field was in many years ago. And they have worked out now some characteristics of patients that will favor towards one biologic rather than another. So I don't think we can answer that question precisely at this point in time. I think we are at the start of the same journey. Antonio?
So I think we need to understand the patients who were studied. Dupilumab were studying patients with chronic bronchitis. See, if my patient has chronic bronchitis, certainly dupilumab will be the alternative. My patient doesn't have chronic bronchitis, I think that patient should be meposulimab.
So which patient phenotypes are most likely to benefit from epithelial cytokine blockade, frequent exacerbators, chronic bronchitis phenotype? So I think, Antonio, you've already answered this by saying we need to wait for the full publications because there's 4 phase 3 studies we're waiting to see. Any comment?
No, I agree. We need to understand the patients. But remember that we talk about, for example, exacerbation phenotypes. For those concepts of exacerbation phenotypes were perfect 15 years ago when patients had 2 exacerbations, 3 exacerbations per year. Today, we don't have those. A patient who has 3 exacerbations per year or 4 exacerbations per year, the first question I ask myself is, are they using their medications? And if they're using the medications, what else do they have? I have a gentleman intubated, and my team said, oh, the 3rd time he's intubated in the last 6 months. I said, listen, stop. I mean, this is not 2025. This is not 1990s. He has to have something else. This gentleman had a huge hiatal hernia. Every time he lay down, he aspirated. He starts sleeping in the recliner, and they fixed his hiatal hernia. His COPD got cured. We never saw him again. So we need to ask why these events are happening, because they are not happening as used to be 10, 50 years ago.
So is the value of biologics in reducing COPD exacerbations mitigated? So I guess that's reduced if a patient's on other agents besides triple therapy, such as azithromycin or roflumilast?
I would say we don't know. Very few people are using roflumilast, and I foresee the roflumilast usage will continue to go down as we have other alternatives to our patients. I have never been very fan of azithromycin for COPD. First, the original study, every day 500 milligrams is a no-go. 250 3 times a week, I was never a big fan of that. Another is some data, but 2025, we have better alternatives. And if you use, please have your patient have their audiology check every 3 months. They don't become deaf slowly. They become deaf suddenly. And I had, unfortunately, several patients who became severe deaf that had made me rethink, what's the value of doing this intervention.
Well, the other practical point to raise about azithromycin is the studies were all 1 year long. And I think you have to be very careful about long therapy over many years because of antibiotic resistance. And that question, then, if the patient's already still exacerbating despite triple and azithromycin, you have to question whether the patient should continue.
And those studies were not done in triple therapy or the medication that we have today.
Yeah. So what's the potential role of biologics? So this is, I think, the acute intervention, the role after a COPD exacerbation treatment. For example, if somebody's exacerbating and concurrently has a respiratory infection, so maybe a viral infection. So I'll kick that one off. So anti-IL-33, tozuracimab, there were some positive early phase data of intervention with this acutely during COVID infection. So that And remember, these alarming cytokines are released by viral infection. So that does give you a scientific case to intervene acutely.
Thank you all. Thank you for being here, for got up early. And please continue this discussion, because the objective of this presentation was to kind of warm you up, to think about it, of all that we're going to hear from the next 4-6 hours. There's a lot. It's a big change coming in our COPD patients. Thank you very much. You'll have a wonderful day.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca Pharmaceuticals. To access all materials for this activity, visit peerview.com/PTU860.